Welcome to InnerSight, Health Optimization with Rudy and Shaun.
Hello, Shaun. Here we are, InnerSight podcast number 11. It's been a great year so far, and we thought it would be quite good to let our listeners know what we've been doing, how the year has gone, what we learned new, what has surprised us, and what confirmed our suspicions that we thought as we went into this year with the podcast. So, yeah.
Excellent. Thanks, Rudy. Yes, I think a lot of people ask, what does the report look like? And what do we test and how does it work? So I think for today, we're going to run through one of our reports, just very basic run through, and just so that people can see more or less what we do.
Yeah, I think you're right. It might have sounded for people looking from the outside that it's like a very involved, like medical, and they are quite surprised, I think, when they get to us, that it's more a chat. It's not the normal doctor. You go in, listen to your heart, have a prostate exam or a pap smear, nothing like that. So yeah, I think it'll be good for people to see what they will see. I don't want to use the word what they will face, what they will see the day that they have an InnerSight report. So,
yeah, so basically, I mean, it entails taking some bloods, doing some basic tests, and then some basic exercise tests as well. Obviously, on the first contact session, we don't want to stress people too much and do a VO2 max and things like that. The idea is to first make sure the ticker is fine, make sure all the boxes are ticked, and then from there on, year 2 or subsequent visits, then we'll move into some of the other tests. But this today is just a basic entry screening test that we do.
Yeah, while you talk about entry, so for people, InnerSight is actually the company's name. So how you get to us is www.innersight.co.za, and then you look for the type of screening you want. So there's obviously the big InnerSight One, where we actually go through everything pretty much as the report is today. And then we've also almost compartmentalize the whole system, that you can actually do little pieces and take a 2 or 3 year view on your health and get the base done, and then add the metabolic, the cardiac, which pieces you want first.
Yeah, so there were some people that maybe didn't want to do the whole program at once. So we've introduced that basic one that you can build onto over time. The basic one will give you cover a couple of things, which is important, and we'll look into that, and if there's red flags there, then we'll probably convert you to the full program. Otherwise, if that one is absolutely normal, then we'll look at other things like family history, etc., to decide, should we do the cardio block next, or should we do the metabolic block next? It all depends on your risk profile. But the one that we're going to talk through today is the InnerSight One program, where we test most of this is our all-covering type of program. And then from there, we'll do other tests if needed.
Okay, so it's going to take us a while, so let's get cracking and go through the report. So if you look at the report, this is pretty much the first page. You'll see what that says is, as we said in our first few podcasts, I think it's our first 3 podcasts about the 4 horsemen, the main thing you want to not have is a heart attack or stroke. So you really want to stay away from arteriovascular disease, and this is what the big blocks at the top will show you, and it'll then be color coded to give us all our risks as either green, yellow, orange, or red.
Yes, I think just people react better to colors. Seeing a red color on your overview, it will get your attention. That's the first thing. We do use a scoring system, which is not percentage based, but it's a point system that we use for ourselves. And basically, it's to guide us. If there's a decline in the score over time, we can pick it up. And I think that's also why it's important to get a medical at least once a year, because there's 2 things. One, the first thing is that people fall off the wagon. That's human nature. And that's just something to bring you back. And the second thing is things change over time. So you might have had a green block on the first session, but the next year something might have changed. So it's important. And yeah, we can pick it up with the color code, and it's easy to spot where we need to work.
Yeah, and I think if we come back to why we wanted to do the year in review, what has surprised me is that that red flag actually gets people attention. So the red and the oranges, people don't like that. So, and we don't like it either. So people are more just a number on a screen doesn't really get your attention. But if you see it's yellow, orange or red, absolutely, people want to move on that. And obviously, we're not just giving you numbers. We're going to give some advice about what is next. So we really don't want to take over your GP's work, but I think our program is built on data. And we really don't want to see you as a person before we see this, because we need to act with you on this and not be the old... like my dad, when he was a GP, you almost want to say to the person, you are okay. But if there's a red block, I can't tell you it's okay. For me and for you, it shows you that there's risks, and let's act on it.
I agree 100%. As doctors, we often want to underplay things. We want to downplay it and say, listen, it's not that bad. But reality, if it's in red on the board, we need to act. Yeah,
no,
and each of those blocks represent the next pages coming up. So we'll take each block then and discuss that with you and what we can do.
Yeah, and we literally pull each one of those blocks in the report. We're going to go over that now. So I'm going to skip through the next one a little bit quickly because it is actually someone's report. It is someone's. So you actually, once you sign in, you get a risk about where you are. You get a form online.
Yeah, online form that you complete.
Yeah.
And one of the online forms that you do complete is a family history. So we call it we use it to basically build a disease tree. And we specifically ask people to spend time on that. Maybe that means you need to pick up the phone and dial your aunt or someone to get some information. But I feel it's very important that you try and fill that history in as good as possible. And as you saw on the previous slide, then we build a disease tree, and it's amazing how you will pick up certain conditions in the family. So if you can see in that disease tree that there's an uncle and the dad's brother and down the line, the risk there's the real risk in that sense.
Yeah, I think that's probably one of the things that surprised me most. We all know we are the product of our mother and our father, but we never think about, or I didn't really think about it as much as when I see this family tree now come through, and you see the blocks, because now you see the blocks, the risk blocks, before you actually see the family tree. As we are taught in medicine, you go family history and then you go to the patient, but now you see the patient or the client before you see the family tree. So you actually see the family tree overlap on the risk data. So it actually, for me, it was like, you are actually a carbon copy. You can see how it follows down actually once you see cardiac risk. I mean, we've seen it so many times. Our cardiac risk just triples down or trickles down. So it's been quite good actually.
So absolutely,
and we have to get that. If you spend time when you do the InnerSight assessment, spend time on that list, because we actually populate it from your own data or that you gave us. So I mean, this type of data is mostly lab data. So this is lab data and what we've actually gotten from you on the nurse's visit.
I mean, yes, going back to that point. So the whole report is built on blood tests, the nurse examination, which includes some fitness tests and measurements and things like that, and the questionnaires that you complete. So it is very important that you do complete those questionnaires as good as possible.
Yeah, absolutely. Okay. let's pull through now. I mean, we talk about your heart, but the heart is like, we talk about the heart and the arteries inside the brain almost as the same. It's the ASCVD risk. So, and if you look at the report, you get sliders, your biological age versus where you are. So this is actually your 10-year risk is, we use most of the stuff as our numbers, but the 10-year risk is actually the Fragingham score that we pretty much built in there. So, which is hundreds of thousands of patients have gone through it. So, and that's rock solid. So we try to build a 30-year picture, and you see this person's slider is at 13%, meaning we think there's 13 out of 100 people, you will be in that 13 at 30 years to have a heart attack or stroke. So,
so we still use the calculators to calculate risk. And because often you'll get the question from someone, my cholesterol is 6.5, do I need to do anything about it? And the question then is, what's your risk? And then this forms part of the puzzle. So this is one piece of the puzzle, is the cardiac risk, and we focus on that 30-year risk. That's what we're looking. If you've got a raised risk at 10 years, then we've almost missed the boat. Then we're almost too late. So 10-year risk must be normal. If it's not normal, then we actually, we need to work hard now to see what we can do. But that 30-year risk is where we can still make a difference, and that's where we're going to work on.
Yeah, and I think coming back to that is, people think that they should not be screened at 30 or 35. We actually think between 30 and 35 is our golden time to screen you. We think before 35 you almost bulletproof. But if we can catch you just after 30 to know the score, and we can say, okay, but maybe we see you in 5 years' time or whatever, but then because then you can pick out the big stuff. I mean, we did have clients this year that had big stuff wrong that we should have picked up 10 years ago. So they would have been read 10 years ago, and we would have prevented stuff. So don't think you should not screen early. I think that's
the only thing with the scoring system is obviously age counts quite a lot. So if you're young, you might have it might give you a normal score, which might not be the case, but that's why we do other tests as well. That's why we look into other things. So it's never one single measurement or result that we look at. We all put all together and we build the puzzle and take it from there.
Yeah. Okay, let's go to our next page. So then, I mean, obviously cholesterol is one of the things that you need in your life. You need cholesterol. Everyone needs cholesterol. But the other side of it, cholesterol, by the things that we've seen, there's a genetic risk factor, which has now been, this last year in the news so much. It's not really a thing that's been tested that much in South Africa. I think we are quite far ahead. Not a lot of, even the cardiologists test that, the lipoprotein. Yours was a little bit high. You should have been screened very early in your life, and
it's one of those funny tests because it's been around for years and years, but only recently we've not discovered, but we established the risk for cardiovascular events with raised lipoprotein a.
And that's a hereditary piece of your lipoprotein A. If it's high, it's high. And if it's low, it's low. So pretty much you need to be screened really once in your life.
Yeah, so currently also we can't do much about it with the medicines available in South Africa. So why do we test it if we can't do much about it? Basically, we just up our aggressiveness on lipids, and we treat the lipids more aggressively. We treat risk factors more aggressively if you've got a raised lipoprotein a. So that's how we treat it then. Some of the newer drugs, there's a lot of action going on. The new CETAP inhibitors, they show to lower lipoprotein a quite a bit. So that might be a game changer going forward. But for now, we need the value to see what's your risk. It's one of the puzzle pieces.
Okay, and then if we jump to the next one, we pretty much talk about ApoB. You can listen to our previous podcasts in the ASCVD, but ApoB is actually now the main predictor of cardiovascular disease as far as cholesterol goes. So if we talk again, so you've got serum cholesterol is your big number, then you get HDL, LDL, and triglycerides. So ApoB lies somewhere between LDL and triglycerides. Somewhere in that size is where your ApoB is. So, and if that is a risk, so this person's was 0.9, which in the old values was not really a problem, but
the lab values still state, below 1.2 is normal. So, and we know it's not normal. We prefer to have our clients at around about 0.6 to 0.8. That's where we're aiming for at least. So even at 0.9, slightly high for us. We would like it into that little bit lower than that. If you can pick two tests for the lipids, it's a protein little a and the ApoB. And that's all we need. Absolutely. We still use the other tests for the calculators and stuff like that, but that's actually the only two that we look at.
And I mean, the LDL is there next, and then your 10-year R score your risk score that we pulled from the previous page, and then your little block at the bottom here will then describe what we say there with the sliders. So, okay, and yeah. If we come back to what we expected, I think we pretty much expected to see a few here and there people, but I mean it's a much bigger problem this in South Africa than I thought.
Yeah, I know. I think almost all our clients have got some lipid issue, and that I don't know if it's our the genes coming from the Netherlands or what the case might be, but we do have quite an issue with lipids in South Africa. The other thing is that, unfortunately, still, and we see it now, unfortunately, still, people are so resistant in taking a statin to lower the lipids, but unfortunately, we don't have a lot of medication available here, or that people can afford.
Yeah.
So we're still stuck with the statins, and ezetimibe is the other one that we can use, but the PCK inhibitors and things like that is just not, people can't afford it, and it's not covered by medical aids for primary prevention.
Yeah, and our other problem is we are a little bit skewed in the people that we've seen, because it's actually people that are proactive, that are looking at their 30-year risk. So we haven't seen really sick people, but in our healthy type population that we've seen, it's been an underlying issue. And quite a lot of the people that I had to say to them, but you are skinny fat. They are actually skinny and well built, but the values don't say the same, which has been quite a surprise.
And hence the reason why we do CAC scans at the moment is just to guide them and show them, because if there's a speckle of calcification, at least you've got something to show them and say, listen, but it's already starting.
Yeah.
Would you reconsider taking some medication to treat that?
Yeah, and we've done quite a few of those scans. So if you want to go back into the radiology and also our ASCVD, so that is actually the scan, a CT scan that we do to actually put a number on this for you. And we've done quite a few of these scans let's take this person. He sees the value from PathCare being under 1.2. We say, if this was mine, I would probably take statins. And then they say, maybe not. And then we say, okay, but let's just get another value behind this to see how much calcium you're actually making. And I think that's a good way to go about it, rather than me putting a stethoscope on your heart and saying, no, everything is fine. So, which is the right way to go about it. Build a risk profile for everyone.
Yeah, and sometimes you need more pieces to build the puzzle.
Yeah. I think the other side, coming back to statins and ezetimibe, is that the side effect profile is actually a lot less. I didn't have to change the drugs or move anyone from or to another drug in the whole year, which was quite interesting.
Yeah.
Okay, and then the next part that you don't want to have is diabetes. So if we talk about glucose, we're pretty much aiming to say, have you got a chance to become a diabetic, or you're pre-diabetic, or you're insulin resistant? And the way to do that is we measure your waist circumference, and you do your fasting insulin level, and then also your HbA1c, which is your average of your 3-month glucose. So it gets laid down and glycosized inside your red cell, and that then gives you a value of your HbA1c. And with that, someone with a HbA1c of 5.4 probably has got a value of about 6.5, somewhere
Average.
there, with a millimole per liter glucose, which means they are not diabetic. And even if they have that value, but they've got a fasting insulin that's raised, what that means is they are being challenged. So the fasting insulin, so thinking about the physiology in with glucose, you stimulate insulin, and then if it's too much, it'll stay high and then flood the liver with glucose.
Yeah, and we've picked up many clients not with diabetes, but the pre-diabetic picture, if you can put it that way.
And I think that was also a surprise.
Yes, I don't think, starting off, I don't think we will find so many.
Yeah, that was really a surprise. And that's when you can do dietary intervention, because once this is moved, it's difficult to change someone's lifestyle if they've moved that far into the picture of a diabetic. But a pre-diabetic, you can say, you know what, cut down on the chocolates at night, and we'll probably
get them moving.
Yeah, exactly.
In the correct way.
And yeah, we'll get to that one. But that's quite interesting. That was a flag for us as well, is that people, I think our way of growing up was PE teaching and all that, is go as hard as you can all the time. And I think it's only now that people are realizing you gotta move, and move slow, but keep moving. Yeah.
Yes, and even my mind has also changed a little bit in that sense that we all had the mentality that just move more, eat less, but sometimes you can use exercise as medicine if you apply it in a certain way, like the Zone 2 training for pre-diabetics.
Yeah.
It makes a huge difference. The other thing is, if you can show them that they've got, already in the early stages, they're more than willing to try something to prevent becoming a diabetic. The odd patient, we will do the oral glucose tolerance test as well, especially if there's a strong family history and they've tested normal. We might consider doing that just to make sure.
Yeah. And that we will send to path care. They take a drink, and then there's a few tests through the next 2 hours to see how your body actually digests and move glucose through the system. So if we just go back, we're trying to get your risk away from the ASCVD, and in that, glucose and then cholesterol. So that was our first two. If we move, then the next killer, the silent killer that people, that was a major surprise for me.
Yeah, no, we all underplayed it.
Yeah.
No, it's not too high. You okay? That's a classical thing that we do as doctors.
Yeah.
And then you set at the blood pressure of 140, 90. Lower is better. It's shown in the studies. In our podcast, we discussed that as well. So I think part of the problem is the testing. Unfortunately, we get that single view of you doing a blood pressure. We spend some time doing blood pressures. We do on your visit. You'll get 3 blood pressures done through the visit, with 5 minutes rest periods in between the testing of the blood pressure to get a reading. And we're much more aggressive on blood pressure than we used to be.
Yeah, and like I say, it was quite interesting for me that we picked up that, quite a few high blood pressures and needed to start medication. And again, not sticky. If people change and they lose a bit of weight, so a lot of the people had weight issues and stuff. So when you move that, you might move your blood pressure, then you can come off the medication again. But it's not worth having that pipe loaded too hard to have a stroke or a heart attack. So, and then the other thing is the uric acid that we test. So we realize that, and through podcast and learning ourselves, we realize that that is also quite a big driver of inflammation kidney-wise, that it pushes up blood pressure. So again, coming back to fructose metabolism.
Yeah, exciting news is a new device from the UK that they've launched, where you can. It's a bracelet that you wear, doing 24/7 blood pressure readings. Unfortunately, they don't ship to South Africa yet. Hopefully soon. But that would be very nice to have that data available. We try at the moment, if someone is borderline high blood pressure, then we ask them to get their own little device and do readings 2 times a day for 14 days and things like that, to get a better idea than just the 3 blood pressures that we do at the clinic. But I think that's going to change the world of diagnosing hypertension with the new devices like that bracelet.
Yeah, and that would be amazing, because then you can actually treat the people. Because I mean, our big problem is we see you and you've got, I mean, if you look at that blood pressure, it's not completely normal, but this is not something we will treat. But it is something you would want to see again, because the moment that 128 moves to 138, then it's a problem. It needs treatment. So
Yes.
it's and that you test it with 24 hours, or test it at a certain time every day. Very much like the heart rate variability was 2-3 years ago, when no one really knew heart rate variability. When do you test it? So that's now become a little bit more mainstream. But that device will be amazing.
No, absolutely. And the thing is, like, we see you once a year maybe, and then a follow-up or 2. Things change. So, yes, 128 is now normal, but next year it might look different. So that's why you need to do at least once a year a decent medical.
Yeah, absolutely. Okay, and then we get a score. So as we said, metabolic risk factors, you have to have 2 or 3 out of, so we put systolic and diastolic there, but yeah, so just to say what is in there: triglycerides, HDL, waist circumference, HbA1c, systolic blood pressure, and diastolic blood pressure. So, I mean, obviously this person has got 0 out of the 6 there, which makes them get 100%. So, meaning they don't have metabolic syndrome. Again, that was a major surprise for me. We have a lot of people with...
Yeah, we don't often see the green bars like that.
Yeah. I mean, it surprised me that I mean, blood pressure was one of the main things, and triglycerides was the other thing that surprised me. We do see people with high triglycerides, and it's mostly, again, diet. You can fix that.
And a lot of our guys, the waist circumference, I mean, a lot of them, they still exercise, they're still relatively healthy, but then when you put down the numbers, they're in high risk category for waist circumference, and you throw in a slightly raised triglyceride or the blood pressure up, and then suddenly you're very close to metabolic syndrome. But then again, seeing the bars the other way around in the red zone, then that motivates you to do something.
Yeah, absolutely, and that will then show us red. I think when you see that red bar, you're like, in your brain it clicks, I've got to do something about it. It is, yeah. I definitely have seen that red light switch people on and say, okay, but I've got to do something about it.
I just think, like, reading the numbers on a piece of paper compared to seeing it in color is just 2 different things.
Yeah, I think talking about the numbers, while we're talking about that now, is we pull a cumulative report of what we can see from your previous stuff as well. So we can see, and now that we're talking about things that surprise me, again, we see so many people that have had high values and high cholesterol values, and then it was not acted on, which was very surprising to me. That
so the question there is, because you get the reports and you're busy and you have many patients, and the patient come in seen by the specialist or the physician or the GP, they draw bloods, they send them home, then the secretary comes or the test results on your table and you scan through them, it's so easy to miss a slightly raised uric acid, for example.
Yeah.
But if you have that cumulative report and you see, but that uric acid has been raised now for 4 years or whatever, then you need to do something about it. Now, we had one client that just had actually quite a high uric acid for 5 years already.
Yeah.
He's doing wonderful now since we've just treated his uric acid.
Yeah, he thought his muscle aches was because of statins, but it wasn't. It was more because he had a low grade gout all the time. So interesting. Okay, and then we get a inflammation score of the inside. So homocysteine, we've talked about in the dementia podcast. Ferritin is your iron stores, and then high sensitivity CRP. So again, CRP, high sensitivity. Why do we do that? Internal inflammation.
Yes, so part of the cardiac risk, obviously, lipids is one part of the problem, but you need inflammation as well. So that's one of the parameters that we look at, and to see if you've got inflammation and a high lipids, then you know the red flags goes on, and we treat it. Ferritin, I didn't realize.
It's been, I mean, it's actually pushed us to have an iron discussion, hopefully on our next podcast. So ferritin shows you your iron stores, and it's been all over the shop. High, low. So females mostly low.
Females low,
and males,
and a couple of males that has had very high ferritin levels, and turned out
we had to screen for hemochromatosis.
Yeah.
I think that is the thing that, I mean, obviously that iron is a little bit of a baby of mine that I've been working on in the last 5 years, but it's really surprised me how many of these ferritins have been abnormal. So it's going to be a fascinating talk when we talk about the iron. So we're hopefully getting a really, really good guest in with that, and save the date for that one. Okay, and then dementia risk again. This person have got a very low risk, but if we talk about family history, level of education, age, smoking, alcohol use, obesity, diabetes, systolic, diastolic blood pressures, ApoB, hearing loss, lack of exercise, low vitamin D, raised homocysteine, and poor omega-3 intake. If I just see that list, vitamin D and omega-3s just shout at me. I mean, most people have got a low vitamin D. So
obviously there's, you can't predict dementia as such, but those factors, they play a role. And I think, if you want to stack the odds with you, not against you, you're going to try and at least get those right. And most of them, other than age, you can do something about, and the other one is family history, obviously. So, yes, vitamin D, homocysteine, easy fixes for those.
And just looking at the thing that otherwise surprised me is actually that a lot less people smoke these days than I thought.
Yes, so that's true.
I don't think I've seen anyone but one that said he smokes, maybe socially, but I didn't see anyone that still smokes.
Yes, but I also do think that the type of client that comes to our clinic, they want to do preventative medicine. So that's probably the, we select a healthy bias type of client that we do get.
Agree with you. We are biased in that one, but I was quite surprised that there were very few smokers, even ex-smokers. So they've been pretty healthy most of their life. So good. If we move on, so then we go to your lungs. We do a peak flow, and then we do a sleep apnea score from the
Stop Bang questionnaire. So that's a questionnaire that we use to just screen for sleep apnea. Also, this is the one that surprised me. Yeah. Often we get an abnormal score there. And then the biggest surprise was how difficult it is to get someone screened for sleep apnea.
Yeah, especially we are in the Western Cape, and we should have centers around, but it is quite difficult.
Yes, it's this a lot of resistance in getting the patient to be screened. First of all, some of the insurance companies, they only will pay if it comes from a specialist. Although, why do you need a specialist if you screen? Treatment is a different story, but screening should be at a general practitioner level. And second of all, it's quite expensive. So if it's an out-of-pocket expense, people, they do something else with the money.
Yeah, and having said that, I think a CAC score should also be. I mean, it's a CT. It should not be a specialist referral.
That's a two test that I've realized is that should be primary screening, a CAC scan. People should have easy access to that, as well as sleep apnea screening. I mean, we've got many clients that need sleep apnea screening, and I probably convert 10% of them to actually go for the testing.
And we've seen it in both ways. We've seen it in the stop bang, but then we've also seen it when we do the testosterone levels, that we see it that there's less stimulation to actually. We see low testosterone levels, and then we see an LH that's slightly low as well. Then we know, but it's coming from here, not that it's actually andropause type.
And then obviously, that's one of the things we want to exclude sleep apnea before you start someone on treatment with testosterone. So, yeah.
Okay, and then we go through your kidneys. We just make sure that everything is running fine. We do a estimated glomerular filtration rate there at the top, and most people or youngsters, and you want to be above 90, so that's the cutoff. And then we do a dipstick, so we literally just look for blood or protein, and then. We pretty much just give you a reason why we are looking at. So mostly in the blocks will be an explanation of what we think. So again, not much to talk about here, but we'll talk about it if they are read. We will go through that. This has been
mind-blowing.
The testosterone screening, what all lies behind it, and when we started, we thought the female hormones were difficult to understand, and we're still trying to get behind everything that's happening with the men. It's been fascinating.
Yeah. So most of the testosterone problems is central. It's either not sleeping well, having too much stress, things like that. Obviously, we don't just start people on treatment. We try and see what we can change. We would like to exclude sleep apnea and things like that. But then at the end of the day, we might need to treat some of these clients.
Yeah.
And we had great successes on people feeling much better. And yet again, we're not treating a number. You need to have the symptoms with it, like something like the Adams score or questionnaire that you can use, or just having a chat with the client and then figuring out if there's, if they do have any symptoms of low testosterone. I found that seldom either they're not telling us or it's not that big a problem. But libido isn't one of the main issues when it comes to low testosterone. I found more the brain fog, the afternoon tiredness, the
listlessness, not drive.
The drive that's gone. That's the main symptoms that most of the guys complain about, which might fall in the slightly low range of testosterone.
Yeah.
The other thing is also the reference ranges for the testosterone. If you compare that to the reference ranges 20 years back, it's different. Your dad had a much higher testosterone, normal testosterone range than what they will say today. So that's something to consider when you're looking at values. But yes, to everyone.
Yeah, it's been.
I think a lot of the guys as well that we see are like extreme endurance athletes as well, and that might also play a role in suppressing that testosterone. Guys that's running high on cortisol levels and things, stress, that will push it down. So but we sit down, we chat with you, we work through it, and then if we can't fix it with the normal lifestyle interventions, and we've excluded certain things like sleep apnea and the others, then we treat.
Yeah.
And we could have a discussion on the testosterone at some point, but there's different ways to do it.
Yeah, we might in the next year bring in someone to talk about this. But I mean, at the end of the day, you want to let someone feel like a man, act like a man for as long as they can. So, I mean, people talk about menopause. We now these days talk about andropause. So when does this actually fall off the cliff? So, and that would also be nice, screening someone early, like at 30 years old, to have a value where you were when you were at your prime, so that we can see. But at some point, you're going to dip down, and I mean, it's been fascinating to see how many, or I think most of the people I tested ran 250 values instead of
333 was actually quite high.
Yeah,
even though you can see centrally is shutting down. So, but I mean, most people
I haven't seen it close to a 600 in a normal person without supplementation, which is interesting. So
and this, everyone is different. So it would be nice to have that value, as you said, when you in your early 30s at the top of your game.
So for the listeners, if you're a youngster, get screened. So we have these values. Actually, when we pull the cumulative report, that we can actually get that in here to know where we should have.
Yeah. So when you reach 50, we can just get you back to 25.
Okay, and then we're doing 2 more hormones. We're doing the thyroid and the vitamin. So I said 2 more hormones there very specifically, because vitamin D is actually a hormone and not a vitamin. It's been
so thyroid. Very, very few abnormalities that we
very few. I haven't seen one.
No.
So I haven't had to put one person on thyroid medication. And on the other side, I did not have to send someone for an ultrasound for a high T4 either.
No.
So I think, again, we might be biased in the people that have been with or to us and with us, but it's been interesting. And just while we're talking about it, and you say this person has got issues, our yellow is like a little blink. It's nothing we need to really jump on. So if we needed to jump on it, it's either orange or red. So this is just keep it in there. So yeah.
And then the vitamin D, sunny South Africa.
Sure. So the pathcare or the laboratory value is under 21 is deficient.
Yeah.
We like to run our people somewhere between 40 and 50.
40, between 40 and 60 in that range is more or less where we would like you.
And then 100 is toxic. So, and we don't really know what toxic look like, because I mean, we've got people that take 5,000 international units daily and they barely get past 60. So very interesting to see how low D3 is. So, I mean, obviously we use a lot of SPF. People don't get in the sun, and when they're in the sun, they really only have little pieces that are in the sun and not. So
yeah, and we also conditioned with all the skin cancers and things like that. We try and keep out of the sun in South Africa as much as possible. So, as you say, clothing and sunscreen. And I think we don't realize how much we indoors in work environment. You think you're outdoors, but you probably weekend, maybe an hour late afternoon, the sun is not that strong anymore. So, yeah, even in sunny South Africa, we're quite low in vitamin D.
Yeah, and that was almost everyone.
Yes, I couldn't believe it.
Yeah. Okay, and we talk about blood and iron. So, like we said, iron was one of our major surprises was that the iron stores are a big issue, especially in women. So, we really need to have that podcast about iron, because I mean, the amount of changes that we see. I mean, part of the InnerSight, we actually now in the lab do a lot of iron infusions for getting people out of that with the stores, getting those stores higher, making people feel themselves again. I mean, it's just amazing the amount of work iron actually does in the body, and if it's low, how bad people actually feel.
Yeah, and on that point, I mean, for those that don't know, we do have at our clinic, we do have an iron infusion clinic there as well. It's not our own clients as such; it's just on referral basis, and a lot of them is to prep them for surgery.
Yeah.
And treating low iron or on a referral basis. So we see it a lot. We obviously, you do the full blood count screen to just make sure there's no funny blood malignancy or something going on. But the main thing that we saw is the iron, both sides, deficient and too much.
Yeah, so the men high, women low. It's like, it was, for me, that was the big surprise out of all of it. And I'm so happy that we've gotten the report, because it makes people feel so much better when they're actually in normal levels. So again, save the date for the next one. Okay, and then we do a basic liver screen. Part of it's your score that you say how much you drink, and then obviously also make sure your liver is not overloaded. There we talk about NAFLD, or non-alcoholic fatty liver disease. So if someone has got a high triglycerides, they've got a big chance of having a high BMI, big waist, and then NAFLD is next if they keep going what they're doing. So we have seen a few abdominal ultrasounds, and they are then commented on that the people have got fatty liver, which is a big issue. You don't, and we then see it on their liver profile. They have raised liver enzymes, which
which can either be from alcohol or, as you said, the other one, which is from the metabolic side. So that's the two things that can cause problems with the liver as such. The alcohol scores, also the questionnaire scores. So try and complete that questionnaire as good as possible. It's a validated questionnaire, but it gives us some information. We need that information.
Yeah. I'm going to move on. So cancer, we actually have seen very few of these, and most people have some type of screening already in place. So for the men, we do prostate. For the girls, we do cervical, and then the lung for both. We just check. Actually, I didn't have to scan anyone for lung so far, so mostly because our people were not smokers and they're still young. Colorectal, I realized how little people have, or how few people, not little, how few people have had colonoscopy by the age of 50. And I think we need to have that come out, that people should have, at least by 50, they should have had a colonoscopy.
Yeah, for me, one of the things is to realize how little we can actually do in cancer screening. And the ones that we can do, we're not doing. So we know we can screen for breast cancer and colon cancer. So we need to do it. That's what we've got available. The prostate cancer, there's a lot of, it's not so sensitive. It's not so easy. And we'll go hard if you've got a family member, like a dad or a brother that has had prostate cancer at an early age. But other than that, the two that stands out is the colon CA and the breast CA. We can screen for that. But all in all, it's actually not a lot of conditions that we can screen for.
Yeah. I mean, the bladder, again, we screen for it, but it's not that common. Even renal cancers. I mean, the melanoma.
So we do a urine dipsticks at least. So we'll pick up if there's abnormalities in the urine, which is not an early sign, which is a late sign. But in the absence of other tests available to us, that's what we do.
In year 2, 3, 4, well, we might move in to do different types of tests. So we are working on that next what we will do next to actually, because we're trying to minimize the risk for yourself when you get through this.
And we early adapters, so as soon as we get our hands on those liquid biopsies, we'll be there to implement them into the clinic.
Melanoma, I've had the scare this year. I've had the melanoma out of the blue. So keep going to the dermatologist to have that screen. I mean, I had no idea that it was even close, and thank God I had that. Diet principles is just something we talk through with this person. Obviously, we didn't need to, because most of the values, but we do spend a lot of time with the people that have got issues, especially the really centrally obese. I mean, we've had a few of those guys, and I mean,
in general, it's almost like religion. So you don't want to talk too much about diet. So that's why we say the principles.
Yeah, so things are changing. I mean, you've now got the Zempic and all kinds of things in the background. I have prescribed it, so it is something that's there. That it's not a fix-all, but there are the SGLT2s. There are a few of the medications that can be used and that you can think about. just remember, once you start that type of thing, it could be that it's for life, because 2/3 of people will need to stay on it to stay thin. So, but it's not that we say no. It is just you have to select the right person.
The other thing is we don't have that long-term data on it yet. So at the moment, our mindset is to start with something like that, and then implement the lifestyle changes and work hard on that, so that we use the medicine as a crutch for a short while, and then take them off it and see if they can stay on their desired weight. I think our population is we're moving away from the mindset of overweight to under muscle. So if we put on some muscle, if we just get people to move a bit more, and we institute something like the medicine to bridge that gap, then the results might be okay.
Yeah, I think that I've missed. I wanted to talk about something that surprised me, and I might bring it in here. Is another medication that surprised me this year was colchicine.
In the cardiovascular.
Yeah, it's interesting. I mean, aspirin was used. My dad used it a lot, and we used it a lot as young doctors in preventative medication. But colchicine has almost now taken over that role
for the cardiac risk patients with residual inflammation. So that's where it's playing the big role. So if that's CRP, the highly sensitive CRP, which is that inflammation marker that we talked about, if you're on your statin treatment and the second drug and fourth, and you still have that inflammation thing, that's where the colchicine, the study shows quite good results in that sphere, just to bring that inflammation down.
We've got a few more minutes. I want to take us through the fitness. So what we do, VO2 max, we did a great podcast on that with Louise Engelbrecht, and we can go through that. But I mean,
so the VO2 max that we populate this report with is an estimated VO2 max. You don't get a stress test VO2 max on your first visit to us. I just want to state that, because that's an estimated one according to a calculator. Sometimes if you do have a Garmin watch with a VO2 max, we'll use that in the report to give us an idea of the VO2 max. Because before we know, we first want to make sure that the ticker is working before we're going to do a VO2 max on you. So we most likely do something like a Cooper test for the VO2 max estimate later in the program, not on your first visit to us.
And there you can see why we do it. We want to check what it would be if you lose 10% per decade, and this person, when he's 80, will be at around 30. We want people around 30 or higher at 80. And our report then describes what this says, and it gives a little bit of an explanation of each one of the headings. We then talk about, so just as that number, before I move on, someone asked me, but why do we do VO2 max? Why do we do grip strength? And it's just because we know the amount of work behind moving that needle. So to move a VO2 max from 44 to 54 means you're training 2 to 3 hours a week extra. So that's why it's such a good predictor, because you know how much someone needs to move that number forward. So hence we use that number. Same thing with the grip strength. You know how many things he must pick up. You know how many strength training he needs to do to have a good grip strength. So the amount of work that lies behind a grip strength is why it's such a good predictor.
And because we like data, we like numbers, and we've got numbers that's validated, and we can compare year on year if that number is moving in the right direction. Yes, absolutely.
And that's why we do push-ups, squats, and grip strength. Again, we can use it year on year on year. It's something that the human will be able to do all the time. So and if you have an injury, we can't use it, but most people.
So if we look at the data of the exercise data, that's still the most important thing that you can do. So the idea, you can almost say you need to start with exercise before you do anything else, if your ticker is fine.
Yeah.
Yeah. So we focus, year 2, we focus a lot more on this side of the equation.
And then flexibility and balance. I think that was another. The closed eye balance was one of our surprises. People don't realize how bad
and
that
an
is.
early age already. I mean, if it's 35, 40-year-old already impaired, imagine at 60.
Yeah, it pushed us to do one of our first guests as a balance expert. Hannes, if you go back into our podcast, we had a great podcast with a biokineticist about balance, and you can actually train this. And if it's not picked up early, it's very difficult to train late. So, we picked it up and surprised us that much that we did one of our first guests as a balance expert. Yeah.
Okay, and then
so this just gives a overview. So you want to be above the gray block, and then we give you a bit of a body metric score. So just again, quite interesting for me was how resistant people are against the BMI. I think probably because our South African population is quite muscular. It is a little bit skewed in the muscular population, but even the guys that had a bit of central obesity was against the BMI. And we sent a few of them for DEXA scans.
Yes.
Then you just say, you know what, if you don't believe that, let's get some numbers, but let's get the validated gold standard in the world. This is what you have. And then you have how much muscle you have, how much fat you have. And then, and that's why we also brought Dr. Hofmelf-Yun in for the radiology talk to help us through all of this.
That's also one of the tests that we would like you to do, so that we've got a number and then repeat it in a year or 2 or 3 to see what happens with your muscle mass and your central obesity and things like that.
And I think that's the 2 things people have to understand. We're not looking just at your fat. We want to have you not have sarcopenia or muscle loss, because muscle loss is a lot later in life is actually so bad that you can actually carry a little bit of fat later in life, but don't lose your muscle.
Don't lose your muscle.
Don't lose your muscle and don't lose your brain.
And you lose it quickly. I mean, when I injured my arm just at 6 weeks in the car, so you can't believe how much muscle you lost in your arm. Yeah. So you need to work on it. And if you don't know where you started, it's difficult. Yeah. It's difficult. It's always good to have some historic values, and to see if you're going in the right direction.
And then you get an overall score of where you are, the slider, which again, validated score, see where you are, and then you've got some data for your next year. And I mean, we're always there in the background, so you can check with us if you want to do some changes or make some changes. We don't want to be your GP, but we want to have you with the data, help you move this needle in the right direction.
And I mean, the discussion is very similar to the discussion we're having now. It's looking at the numbers, chatting about it, see what we can do. What are you willing to do to change some of those numbers? It's very informal, but if we manage it early, the results when you're 80 will just be so much better.
Yeah. And then the rest of the report is really just a summary so you can take to your doctor and say, I've had some data done on me, have a look at this. It really explains what we've been doing. And then we give you a report of your numbers. So you literally have your own numbers from the laboratory in your report. And we can send that to you digital, but you have the physical report because we do a physical one-on-one with you. And I mean...
so that's one of the other things. It's your life. It's your data. You own your data. Okay, so it's important that you have your data. So you can go any place in the world, you have your data with you, and you can show people. If something happens to you, you've got it available to tell people, but this is my baseline.
Yeah. So coming back is we've seen a few surprises. We validated a lot of stuff. And I think the other thing is we wanted to show our audience this is actually what it looks like. It's literally, people don't have to be scared. And the other thing is what I always tell people: everyone's got something. And me and you started with this journey because we had something, and both of our numbers look a lot better because we've gone through the system. You check mine, I check yours. And that is what we want to do. We want to get people better and actually have an understanding what is the thing that's going to get you to a good 80.
Excellent.
Good. So
Thanks for looking after me, Rudy.
yeah, and save the date for the next one. I'm so excited to have our guest about the iron, because that was one of our big surprises. See you next month.
Next month.
Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.